I am starting the recording. You guys should see that, letting everyone know that it's being recorded at the top. Your consent is the fact that you've stayed. But this way we can access this information at the end. Angela, if you can somehow get your phone to move down just a bit, I have your forehead. And that's it. I mean, it's a lovely forehead.
If I have to hold this the whole time, it's not going to be pretty.
That's good.
But you are. There we go.
Yeah.
So I've already introduced myself. I'm Elizabeth Johnson Phillips, and we are also here with Tommie Deaner, who is our HR expert, and Angela Simmons. I want to remind everyone, if you're not talking, to mute your self. That would be great. So we're going to start off. Tommie, if you could tell us a little bit about who you are and your expertise, and then we'll get to Angela, and then we'll get the ball rolling.
Great. Well, thank you so much. I'm super excited to be here today with you guys. I'm Tommie Deaner, and I've been in human resources for over 20 years, working in various settings. And obviously with the COVID-19 pandemic, lots of things for employers to consider from an employee perspective, especially as you start to reintroduce your individuals into the workforce. So I'm excited to be talking about some of the challenges and things that you might want to think about from that perspective.
All right. I think I know most of the people who are on the call today, and most of you know who I am as well. And so I will be speaking to you. And I know this is the thing that is probably foremost in your minds is what do we need to do as we get back into the workplace to keep ourselves safe, so employees safe, and then what do we need to do also to keep our patients safe? How do we move forward in this new era? And so I will be addressing the infection control, OSHA, and all the guidelines that are sitting out there today.
Okay. So with that, I know one question, and I have spoken with some people as well. And the first question is kind of a hybrid of both HR and compliance, in that they're going to factor into this. And I think in general, everyone is on a spectrum of anxiety about coronavirus. Let's say it's, on a scale of 1 to 10, 1 is just living life, and 10 is like a panicked alarm. And so one question I have for you is what to do when, say, the staff are at a 10, but your doctors are at a 5. How do we bridge the gap? And it's probably the reality is everyone in an office has a different scale. And that scale probably changes from day to day, from moment to moment, dependent upon what they've seen on Facebook, what their best friend's sister's brother has said to someone they know in real life, and how that's affected them. So how do we bridge that gap so that everyone can be on the same page and move forward?
So I think there's going to be an HR perspective to anything that we look at, especially as we go back into the workplace. But this really is going to come down to educating, training our employees, and doing and putting into place things that were already there for us. If we look at all of the guidance that has been put out during this pandemic, it all points back to what we already knew. And so part of this is don't work sick. If you're sick, stay home. And we need to make sure the employers are on board with that and not making employees go get a sick note, go to the doctor and get a note because I don't feel good. And I have to have that note in order to miss work. There is a published list that tells us, coronavirus, I'm sure will be added to this list. If you have X condition, this is how long you need to stay out of the workplace. And so one that's very familiar to everybody on this call, herpes whitlow. So that's something that caused by the HSV, herpes simplex virus. It's called whitlow when it's on your hands. And the time that you stay out of work for that is until it is completely clear. And so it is going to be education, right? Don't work sick. The other part of this is we have to quit treating sick patients. We're in dental practices, not hospitals. We're not treating them for colds. We're not treating them for the flu. They may have emergencies that are going on, and they're sick, but I think that we're going to have to reevaluate how we treat the emergent and sick patient, because we don't have airborne isolation rooms, infection isolation rooms in a dental setting. So do we have to consider that maybe if I've got somebody who's got a respiratory problem and they've got a dental emergency, what's our protocol going to be for that? Do we have hospitals or other settings in our area that will be able to treat those patients? So I think, you know, the big thing is don't work sick, don't treat sick patients. The other aspect of this is that we do have a lot of things that are in place that we have simply kind of stepped away from. If you look at, can you see me, Elizabeth? What do I need to do?
You're doing good. I can see.
Okay.
I can see. This is where I can see. So like here.
Can you see?
That's the part of you I want to see.
Can you see me now? Okay.
I can see you now.
We have a lot of things that have always been in place, and so we have some old school techniques that have been in school for the operative side, but then we have some newer products that are in place for both operative and hygiene. And so, first of all, let's get back to the rubber dam, right? When we use a rubber dam with our patients, what we are doing is we are effectively keeping their normal flora, their oral flora, on the other side of that rubber dam. We're only exposing the area that we're working on. And so that greatly reduces the likelihood that we're going to aerosolize something that's going to make you sick. The second aspect to this, or another thought process, is that obviously you can't use a rubber dam if you're the hygienist. But you know what? You can use ISO 3, or you can use ISO VAC. The Pure VAC, and the dental people on the call, I think, understand the terminology. We do have a product called a Pure VAC, but what that basically does is puts a mirror onto the end of our HVE, so that I don't have to hold a mirror, because I can't hold suction, a mirror, and a scaler or a curette while I'm working on the patient. You don't have three hands, you can't do it. And so what they try to do is remove the Pure VAC, removes the need to hold a mirror. That's not going to do anything to reduce aerosolization. The HVE in and of itself does, because that's what it's designed to do, is suction. However, what everything is showing right now is if we will use the ISOLite products that are out there, we'll be able to even more greatly reduce the amount of aerosolization that our healthcare workers are exposed to. And the ISO VAC is recommended for hygiene. And so I think that is something that we're going to have to look at in dental practices. The mouthpieces are autoclavable, which is good, because when you start thinking about cost, right, if they're all single use, then your costs are obviously going to rise. But we're going to have to rethink, we're going to have to relook, and we're going to have to do a little bit of going backwards and looking at what we should have been doing all along.
I think to add on to sort of what Angela said in terms of managing the anxiety level of your employees coming back into the office, again, having clear policies and procedures, both the protective policies like Angela is talking about, as well as your workplace policies, making sure that your employees understand the things that you are doing to help keep them safe. And then also talking to your employees about just where they are. Some of them may have stress related to COVID-19 because their kids are home and they're out of school, so they're trying to juggle different things. So again, keeping those open lines of communication and education open between you and your employees are going to really help with that anxiety level coming back into the workplace.
Yeah. So one of the things for the people that are on this call, because these are, I think, the largest majority are my clients. If you're not, let's talk. But if you're my client, one of the things that we are going to be looking at is we're going to strengthen, because we needed to have this in place, but we didn't have a concern for COVID-19 until 2020. We need a strong infection control policy. We need a strong respiratory control policy. And those are included in the current OSHA manual, but we're going to go back in and strengthen those. And part of strengthen those to add information about the respiratory-based precautions or transmission-based precautions, but also to make, to give some room for the practice to say, absolutely by policy, you can't work sick. And I think that's an important thing. And then what is the guideline that will allow the employee to come back? So if you've had the flu, how long do you have to wait before you can come back to work? And that's all based on science. We have actually, the CDC has produced a list, and we will actually add that into our infection control plan so that you have it. And as we get more updates from the CDC, because that's where our guidance will come from on that, we will continue to update that for our clients.
Now, one question I have had, you just were mentioning the CDC, the different guidelines for the protection of employees. There's CDC recommendations, there's OSHA recommendations, there's ADA recommendations. Do all of these recommendations say the same thing? Who do we follow? Are all of the recommendations required? What initials do we need to listen to in what order?
Okay, so first order is OSHA, because OSHA is regulatory. So there's a huge difference in what is guidance versus what is law. And OSHA is law. But OSHA does rely on the CDC to help develop guidelines. So OSHA says you have to wear personal protective equipment. We rely on the CDC to help us know what procedure requires what type of personal protective equipment. So they work hand in hand. Now, the other thing that you have to recognize with the CDC is, even though it is guideline as opposed to regulation, if your state board has adopted CDC guidelines, it's law. That's already been the case here in Virginia. But Governor Northam made a really good statement a few weeks back. Whatever new guidance was put out, Virginia is going to follow. Now, the guidance that has been put out by OSHA for COVID-19 is a reiteration of what was already in place. There is nothing new in that guidance. And I think that's an important thing for employees to understand. One of the things that I definitely want to explain here is, first of all, we are afraid of coronavirus because it's new, right? So that is part of the aspect. We're hearing a lot about it. We are social distancing. We have taken our kids out of school. We've closed down businesses. And so this has that effect of scaring people. But let's talk about just a little bit of science behind a virus. So when we look at viruses and what is the most difficult to kill versus what is the hardest to kill, the small enveloped viruses are very easy to kill. Guess what coronavirus is? Small enveloped virus. The harder kills are the small and the large unenveloped viruses. So when we start thinking about that, and we think about our surfaces and how well the virus will be able to live on a surface if we're doing the right things, we already have products that have kill claims that will kill coronavirus. If you've got a product that says it kills rhinovirus, rotavirus, norovirus, all of those are products that will absolutely kill coronavirus. Coronavirus is a much easier kill claim.
So it's sometimes just a matter of actually doing what we should have been doing all along.
It is a big portion of this is going to be doing what we should have been doing all along. A really big portion of it. Some of the, a couple of things that I think, you know, so if you know, to reiterate something that I've already said, right? Let's go back to what we knew we should have been doing. Let's wear our personal protective equipment appropriately, right? Don't work if you're sick. Do not treat sick patients. We are not hospitals. If they have respiratory symptoms, send them home. We need to screen our patients. We need to know what is out there and what the guidelines are to protect employees. Part of that is, first of all, making sure that immunization is in play for your employees. That's number one. Are they up to date on their immunizations? Then we assess what the hazards are, what their exposure risks are within that practice. We add in hand hygiene, we add in personal protective equipment, we add in sterilization, we add in safety devices, and we add in disposal of our regulated medical waste. Those are all things, everybody on this call today, those are all things that sound very familiar to them because that's the basis of standard precautions. This is what we've already had in place. The big question that we have at this point is, are we going to have to use N95s versus the level 3 masks in the dental setting today?
So what's the answer to that question? That's one of my ones. If we're talking about PPE, you know, who needs an N95? Who needs a lower tier mask? Who, you know, is that front desk staff sewing mask at home? What's going on?
All right. So homemade masks are not appropriate for clinical employees, period. Homemade mask, if we want to put a mask on our front desk folks, homemade masks are fine. We do not want to use our medical grade personal protective equipment with front desk staff, because what we are doing is creating a shortage then for our clinical staff. The only level of mask that has ever been recommended, and what we follow when we are selecting masks for different industry, we follow the American Society for Testing and Materials. And so the American Society for Testing and Materials has long had the stance that a level 3 is what we need in the dental setting because we have aerosolization, right? So we know we're going to have aerosolization. We know we're going to have droplet. The N95 is when we know we're dealing with infectious disease. So the important piece there is when we know we're dealing with infectious disease. So if we eliminate the treating sick patients, that's number one, right? Quit treating sick patients. The other thing that we're going to have to look at, so there's nothing that says outright you have to wear an N95 in the dental setting, but a couple of things that we are going to have to consider. Practices can elect to make that a part of their policy that their employees will wear N95s. They will have to make sure that they do the initial fit testing. Right now, the annual fit testing requirements have been waived because of the pandemic. That won't be forever. That is just during this pandemic period. But any mask that is subject to aerosolization is a single-use mask. And that's the other aspect that we have to remember. As masks become wet, and so we have to think in the dental setting, they get wet from the patient side because we have spray and spatter. They also get wet from the employee side because we have humidity in our breath. So that moisture, what that does is degrades the mask, and the mask does not filter as well. So with an N95, an employee, if you were in a medical setting where you could put an N95 on and wear it all day, you would know that the N95 had reached its life expectancy because it would get more difficult for them to breathe, and they would be able to start smelling odors outside of the mask itself. So it's easier in that medical setting for them to know when the mask is degraded too much. But the rules are very clear. If it's subject to aerosolization, it's single use. The risk of cross-contamination is too great.
One thing as you're thinking about reintroducing your staff back into the office is that some of your team members, like your front desk staff, aren't used to wearing masks. And so making sure that you train them if you're going to have them wear masks versus your clinical staff who know how to handle them properly. People touching the front of the mask, which is where the contamination might be if they're wearing a homemade mask. So if you're reintroducing your staff members to the office and you want them to wear masks at the front desk, make sure that the folks that aren't used to wearing the masks understand how to treat them so that they don't contaminate themselves accidentally as well.
Tommie, from an HR perspective, what else can practice managers and dentists do to help maybe our front of staff, well, probably all of the staff, feel more at ease?
Yeah, I think it gets back to sort of what Angela's been really talking about from the beginning, is just educating your team members about the safety protocols that you have in place and why you're putting them in place so that they can get a sense of comfort and ease that they're protected when they come to work. I think also just making sure that you're communicating with your employees to understand, again, where their concerns are and trying to address those proactively. You may need to evaluate some of your workplace policies around, let's say, common areas, kitchens, the coffee machine, and making sure that you're clearly communicating those things well in advance of people coming back to work so that they have a sense of understanding that you're taking every step that you can take to keep them safe.
Now, Angela, there's a couple of things this is not our first webinar together. And so there's a couple of things that you've said on some other webinars that I think are applicable here in regards to reducing everyone's risk in terms of how patients should be queried about whether they've traveled, what their respiratory illnesses you've mentioned before prior to even coming into the office, what that looks like. And I also want you to talk about your recommendations for waiting rooms and what that would look like.
So one of the things, let's hit waiting rooms first. So I will just tell you, and anybody that's ever listened to me do a training has probably heard me say this. 25 years ago, when our patients went into the dental operatory, the patient went into the dental operatory, not the patient and their 3 children and the teenager across the street who thinks they might want to be a hygienist or a dentist, and the person who was just curious because you're going to extract my tooth today. People are coming into dental practices and they are bringing families and communities with them. So number one is we've got to develop some policies that say that we're going to have the patient and maybe one other person. If they're, obviously you can't just send a 5-year-old into a dental practice and tell them to sit in the waiting area, right? But we have to think through this, and we've got to be a little bit smarter, I think, about what we're allowing to happen. The other thing that we have to consider is, and dental people know this, our spray and spatter zone from the mouth is 3 to 6 feet. In between patients, we only clean our clinical or disinfect our clinical contact surfaces. We do not disinfect housekeeping surfaces in between patients. So those are floors and walls, and it may even be the front of a drawer, cabinet handles, things like that. So if we are allowing patients to bring their children into dental operatories, and we're allowing those children to crawl around on the floor, to touch items, to sit there while we work in mom or dad's or the sibling's mouth, and they're being exposed to the aerosolization, what are we doing? We have to really go back to what we originally knew we should be doing, and make sure that we're protecting our employees, we are protecting our patients and their families, even if they don't realize we need to do that for them. Your 3-year-old should not be sitting on the floor. Your newborn baby should not be sitting on the floor in a dental operatory. They shouldn't be sitting in a dental operatory. We want to make sure that we absolutely protect them. At a front desk, or so bringing patients in. We have moved from an era of where we traditionally would call and confirm appointments with our patients. And so then you could find out, if the patient doesn't feel good, et cetera. So now we've moved to more of the e-confirming. So they're getting text messages, right? And this doesn't give them the opportunity, and it doesn't give us the opportunity to say, hey, have you had any respiratory symptoms? Have you had a cough? Have you had a fever? Have you traveled outside of the country? So I think we're going to have to reevaluate that. Is there a way to get those messages in or get that verbiage into our e-reminders for our patients? Or are we going to have to start making the phone calls again? Are we going to have to set a time of the year when we do this? So cold and flu season and maybe cold flu COVID-19 season, right? When are the times that we're going to have to actually talk to our patients? And considering not having waiting areas, but keeping people in their vehicles. I think about that just any given day. If you have somebody come into your office and maybe they don't even know that they have the flu, but they sit there with 20 other people in your waiting area, what are we doing? We're transmitting. And so I think there's a lot of things that we're going to have to reconsider, that we're going to have to think about, that we're going to have to do in order to make sure that we're keeping our employees safe, we're keeping the patients safe, we're keeping our communities safe. And at the end of the day, I've said this to most of the people on this line, at the end of the day, what we want is we want our employees to come in and go home the same as they did when they got there that morning. We don't want you. We want you to be safe, and we want your families to be safe. So we're going to have to rethink the PPE, the personal protective equipment piece, a whole lot. Traditionally, in a dental practice, jackets are worn until they are visibly soiled, right? So this means patient to patient to patient, I'm wearing the same jacket. And so do we need to consider this now? Do we need to make sure that instead of wearing waist length jackets, that we are wearing knee length, because we know that when our operators and our assistants and our hygienists are sitting in the chair, their knees are exposed. And so the clothing that they have on, if they're wearing that home, they're taking home microorganisms, they're taking home potential pathogens to their families. And so we have to think about that. Are we going to change after every patient? Are we going to wear longer jackets? And then we have to consider if we're going to put hair nets on or some head protection on, because let's face it, you are exposed to spray and spatter all day long. If you see 10 patients, you're going home with 10 patients spit in your hair. And that is a really big concern.
Yes, it is. Also, I will say my first job was calling patients to confirm appointments. Just like let everyone know.
You were pretty safe.
That was my job. That was my first job. Well, I feel like there. So in terms of, I know we have on our website one of the initial screening things. I'll make sure in the follow-up email I send to everyone a link to those screening questions that you can be asking patients. Because honestly, my guess is the patients are going to be anxious as well, and so we'll probably be calling you to say, "Hey, I have this appointment." And then you can use that opportunity to speak to them. I have had a couple questions come in, and one of them is saying, Annette is asking, saying, so are you saying that we do not need N95 masks?
What I am saying is that what the guidance says for an N95 is that they are worn when we know that we have known or suspected respiratory infectious disease and we have aerosolization involved. An office can elect to make the N95 a required part of their personal protective equipment. And that's really the discussion that we're going to have, because there's a couple of things I want to say about that. So number one, obviously we know that we have evidence of asymptomatic carriers. Any disease process, that happens. So what's the likelihood that we're going to have an N90, a patient come in who does not know that they have COVID or doesn't know they have the flu? We've been doing this for years, right? How many patients have we treated that didn't realize till that night that they had the flu? So we could make N95s a requirement. But the flip side of that coin, right? So there's always two sides to a coin. The flip side to that coin is this, and this is something that I mentioned to Tommie and to Elizabeth earlier. Right now, what all of the experts are saying, the epidemiologists are saying, is that we need to make sure, or that in order for us to develop herd immunity, with HERD, you've heard me, again, anybody that's ever heard me train has heard me talk about that. In order for us to develop herd immunity against COVID-19, 60% of our population is going to have antibodies. And right now, we have about 5%. And so how are we going to get, right, without just, like when I was a kid, if somebody on the block had chickenpox, like all of our parents got us all together because they wanted us to all get chickenpox at the same time. Now we have a varicella vaccine, right? So we're not as, and that doesn't, and it's probably child abuse today. So we don't do that. And that would, that would obviously not be a responsible thing to do. But how are we going, and this is something that the scientists and the epidemiologists will have to look at. How are we going to get to this point where we do have enough people who have the antibodies that it is less of a panic? Right now in the state of Virginia, we are testing 2,000 to 3,000 individuals per day. The goal for our state is to get up to 10,000 daily. So the more people that we test, the easier it will be for the experts to say, hey, yeah, you really do need to do X, or you really do need to do Y, or we're in a really good position right now because we estimate this percentage of the population has antibodies to coronavirus.
I just had a question come through about that gowns are unavailable.
Yeah, and so one of the things, if your PPE is unavailable, we don't need to be doing elective work, right? And hygiene is elective. So unless we have the appropriate PPE to protect our employees, we do not need to put them in situations where they are going to be exposed, because then their families are going to be exposed. And it's simply not okay. I think there's a lot of risk management with that. There's probably an HR perspective to that. We have got to put our employees first. If we put our employees first, then we're going to protect our patients. So if you do not have the appropriate PPE, you cannot see patients. Cloth masks are not okay for our hygienists and our dental assistants and our dentists. If you don't have the appropriate jacket to protect yourself, it's not okay. One of the things we'll have to consider is, if we're wearing the launderable jackets, do we have enough that we can take those off? And what's our policy going to be? Because there's been no change in regulation surrounding the jackets, right? And there's been no position statement that says we need to do X now with our jackets, where we've traditionally only changed them when they were visibly soiled.
And I think, Angela, that's a good point, is that I think with COVID-19, you're going to see a lot more heightened sensitivity to adherence to the existing regulations and rules. And so as employers, I think we're going to see employees really demanding some of this enforcement continue to occur. So that's something, as you're preparing to bring people back, to be prepared for, that they're going to want to see these measures in place, and they're going to want to see this adherence to it, as we should.
One thing that I'd like to, I know we're getting close on time. One of the things that I would like to kind of go back and touch on for the dental care workers, the dental health care workers, our frontline folks. I have sitting in front of me, and this was something that the Garrisonville and the Lightweight folks will be talking to at 3 o'clock. The EPA has put out a list of currently on the market disinfectants that are absolutely effective against coronavirus. Coronavirus is not new in and of itself. We have known about coronavirus for years. Happens in our pets. It's something that occurs in pets. They do get immunizations for that. Please don't drop your pets off at the local shelter or the side of the road, because there's no evidence to suggest that you can get coronavirus from your pets. Otherwise, we would have all had it long before 2020. But I've got a really good list. And as I looked through the list, most of the products that I see when I go into dental practices are on that list, right? So if you're using Cava wipes, if you're using the Santa cloths, you're using Cava 1, you're using Optum 33, most all of these products are listed on here. And I've even got down to the kill time, right? I only pulled a 1 to 3 minute kill time because we don't have 10 minutes in between patients. So that's something we'll be sharing with you as well.
Okay, I do have a question here. Can you give us a list of appropriate PPE? What do we need to be wearing from head to toe? Do we need face shields? And are level 3 masks okay when using ultrasonics?
So, all right. So if somebody were asking Angela, what should I do for my hygienists? They should have surgical caps. We need to protect their hair, right? They always have to wear their safety glasses. There's no getting around that. Level 3 mask is what is prescribed. We can use an N95. You can put a face shield over the mask. A face shield replaces safety glasses, but it never replaces a mask. So even if you have an N95 on, or excuse me, yeah, if you're wearing the face shield, whether it's a level 3 or an N95, you would still have to have that mask in place. You can never take that part out of it. We should have on jackets or gowns. My recommendation would be that they're knee length. And of course, we should be wearing gloves when we're working with our patients. The one thing that I am absolutely going to recommend for all of my dental practices is that we look at ISOVAC for our for our hygienists. They need to have that in place. That's going to do the most to reduce aerosolization for them during each of their appointments throughout the day. The HPE does reduce it, but it doesn't reduce it as greatly as the ISOVAC does. And that's because the ISOVAC, when we look at that, and you guys probably have seen, anybody on this call's probably seen ISOLite used at some point in time. It really acts as a pretty good barrier, and it is designed to pull the patient's saliva and all of the water that we're introducing as well back in. It hooks into our HPE. They know what that is. Hooks back into our cords for our tubing for our HPE and evacuates that out of the patient's mouth, reducing the aerosolization.
Okay, as we sort of wind down the end of the hour, one thing you have mentioned a couple times, making sure that we have all of these policies in place. From both an HR standpoint and a compliance standpoint, what policies should an employee expect to receive, and that physicians and practice managers need to make sure that they've reviewed and are up to date and, current what they need to have?
I think from an OSHA perspective, or I know from an OSHA perspective, there's a couple of things I think about it. I know what's required from an OSHA perspective, but I think that we have to get back to doing a better job of making sure that the information is shared with our employees. It can't be checking a box, and that's what we do. We have OSHA policy, but it's got dust on it, or the file's never been opened. The employees have no idea what that policy says. From an OSHA perspective, we have to have an exposure control plan, and that's what would address the COVID-19 piece of it, as well as an infection control plan. So that helps address both employee and patient safety. We also have to have hazard communication plans, emergency plans, radiation safety plans. All of those should be in place, and our employees should be well aware of what those policies are, or at least have some knowledge, and then know where to find those policies. So if I've got a question, X happened, and I'm not quite sure what to do, I know where the OSHA manual is, or I know who the safety officer is, and I can go ask that person, or I know how to get a hold of Angela, and I'm going to send her a text because everybody knows I like texts.
She does. I can speak to that.
I would say from an HR perspective is really making sure that you establish your expectations up front as you bring people back into the workplace. So, what's your social distancing stance in terms of your waiting areas with your patients, within common areas in the workplace. I think making sure that you're clear about your expectations about not working sick, as Angela said. And some of the things, just reinforcing again some of the basics with your employees, like the kill time, right? Like reinforcing like what a proper cleaning procedure might look like. Are there certain surfaces that you need to wipe off more frequently now that we're in this pandemic? So different issues like that. I think you need to spend some time up front making sure that your employees have clear expectations. Maybe even starting to leverage using pre-job briefings so that everybody's on the same page when you do like a morning huddle, so that everybody's working together to make sure that you have the appropriate procedures. And again, I think that will help alleviate employee concerns because that they know that you're focused on it and you're serious about it.
So interesting, Tommie, that you say that, because as I was listening to everything that you said there, again, what you just said is we need to start doing what we already knew. One of the things that I always say to my clients is whatever disinfectant you're using, know your kill time and write the kill time on the top of the canister. But most people are using wipes today. So write the kill time on the top of the canister so that anybody that picks that up knows how long the surface has to stay wet. Part of disinfection, the CDC guidelines for sterilization and disinfection, I cover that in training with my clients. I have a 3-hour infection control training that I know everybody's just biting at the chomp to sit and listen to.
It's awesome.
I know, I've done that with Garrisonville Dental. But it is, I think that we need to spend some time getting back to some basics and just retraining and reiterating what we absolutely know from a science standpoint, and then what can we do from the employer standpoint to help reinforce that and to help make our employees feel better. Some of this anxiety that we are feeling around COVID-19, some of it, so obviously there's a good portion of that is, oh my God, I work in a field where I'm going to be exposed to this. But the other piece of this is, and I think this is a piece that we maybe don't recognize as easily, is that there is a bit of a mental health perspective to this. We have all had our lives like, boom, go to your houses, stay home, social distance. You can't, I can talk to my parents on the phone, but I can't go visit them. I can talk to my mother-in-law on the phone, but I can't, she's 30 minutes away. My sister-in-law's birthday was a couple weeks ago. We didn't get to go celebrate. My grandson had his 9th birthday at home with us. So, I think we're getting some cabin fever. Yeah, we're grieving. We're getting some cabin fever. We've got a grieving process. I will tell you, when I'm out and I see people wearing masks, it has an impact on me because I am looking at it and I am thinking, what has happened, right? Because this is not what we're used to. And so seeing our malls shut down, seeing our restaurants shut down, not seeing people out and about in our neighborhoods and on the street, being able to, I think I could probably drive to DC today and not have any traffic issues. But I think all of those things we have to understand, and we do need, as employers, I think, to be cognizant of that and sensitive to that this has impacted us all in many different ways. And we have got to be sensitive to what the concerns of our employees are. And I don't say to the mental health status in a negative way. Being isolated has an impact on your mind. There's no getting around that.
Yeah. And I think as leaders, it's important for us to, be leaders and to show the way, and to make sure that, we are taking the time to make sure that we know how our employees are doing, how they're feeling. So it's more than just reopening your office doors and walking in patients. It's about making sure that your staff, where they are, how they're feeling, what they're struggling with, and showing the way in terms of leadership around good practices, good policies, good procedures.
We have kind of reached the end of our time, and I think that we actually are at a good spot in terms of talking about how this has affected all of us and collectively. And I am desperately hoping that we can open things up. It's not going to be the same as it was before, but in whatever way we sort of ease into it slowly and able to keep all of employees safe, both mentally and physically. That's important. And we work as a team. And so I just want to thank everyone for coming and apologize for, and thank you for being gracious to us in regards of our technical stuff. I'm going to whip up a transcript of this, because I think, and I'll send you a link of this, but I'm going to type up a transcript, because that might be a little bit easier to process with some of the technical issues that we've had. If you have any further questions, feel free. You can send them to me. I'm EJ Phillips at MPWRSource.com. You can also, Angela, can you give us your email address?
Angela at CentraVance.com. I will answer any questions, folks. The other thing I want to say is I got a 3 o'clock today with Lightwave Dental and all of their folks that's going to be just longer and more detailed and allow for more open questioning. So anybody that's on this, whether you're a part of Lightwave or not, if you want to join it, just send an email to me, Angela at CentraVance, or send it back to the email that you joined this webinar on, and they'll get you in touch with me so that we can get you onto that call this afternoon at 3 o'clock. I want to make it open and available. I want to be able to answer questions. I want to do what we can to allay as many fears as we can, and to think about what kind of changes we're going to make and help implement those changes as we go back.
Yes, definitely. So thanks y'all for joining us. Stay safe, and we look forward to hearing from you again.
Okay.
Bye. Thanks.
Thank you.
Bye.